Hi guys, we're going to talk about anger, aggression, and violence. In this chapter, we're going to try to just define each of those concepts and then just talk through how the nurse would respond if they had a patient showing these signs and symptoms. So let's get started here. So abuse, aggression, and violence can have a significant influence on a person's life. Clients experiencing abuse, aggression, or violence can develop mental health disorders as well as being subjected to physical trauma. So you can see some of the systematic strategies used to obtain dominance and control over others, which we would consider abuse, and that can be performed psychologically, physically, emotionally, economically, or even sexually. So as we look closer at physical abuse, perpetrators of physical abuse may use force, including kicking, hitting, slapping, pushing, strangling, or biting to control how others behave and think. So what will some of these patients look like? Generally, you may see ripped or torn clothing, broken eyewear, disheveled hair, maybe even clothing. As far as what the nurse may not see are those bruises, lacerations, burn marks, fractured bones, punctured wounds, wounds in various stages of healing. So nurses have to, you see that general appearance, you have to like red flags should go up that you need to do further assessment. You may encounter these clients in all aspects of acute and long-term care and should be cognizant of presenting manifestations. So just what they appear like on the outside could give you a bigger story on the inside. When we think about emotional abuse, the person responsible for abusing others may use threats, insults, and intimidation to exert control. This may be harder for the nurse to recognize as there's really no physical evidence that is apparent. So what are some of the potential signs that we may see as nurses? Changes in behavior, loss of self-esteem, maybe anxiety provoked by the presence of certain people. So if you see somebody walk into a room and all of a sudden your patient gets more anxious, that should be a red flag for you. Or maybe claims of enduring verbal or mental mistreatment. Individuals who have experienced abuse are at higher risk for developing substance use disorders, anxiety disorders, depressive disorders, eating disorders, borderline personality disorders, and post-traumatic stress. Sexual abuse is any forced, inappropriate, or unwanted sexual conduct or sexual abuse. This includes photographs that may be sexually explicit, indecent exposures, unwanted touching, rape, force to engage in sexual acts, or coerced nudity. Digital media and online resources have simplified the grooming, luring, and exposure of children and adolescents to those unwanted sexual explicit content, which is really concerning for our human trafficking population. Financial abuse is misuse of another person's financial resources with or without their permission. Some of the potential signs that you may see are sudden bank and accounting changes, abrupt changes in availability of funds, individuals that don't remember signing financial records, or maybe individual reports of exploitation. So some of the examples that might be included are stealing, forging checks, promising to pay bills for a person, but then keeping the money for themselves, and maybe even falsifying wills or financial records. So we've talked about abuse. Now we're going to switch gears and talk a little bit about anger and aggression. So when we think about anger, this is an intense emotion with both positive and negative effects. If anger is unrestrained, it can result in harmful physical and emotional effects, including hypertension, headaches, insomnia, digestive issues, and possibly harm to self or others. It could be displayed with cursing, sarcasm, yelling, breaking objects, making a fist, but it is not often followed by an aggressive act. When we think about aggression, on the other hand, this is the actual action intended to cause harm, and it can be either physical, psychological, or both. Aggression tends to be used synonymously with violence. However, aggression is not always inappropriate and is sometimes necessary for self-protection. So as we continue to look at aggression, some examples for each of these sectors of aggression include using coercion and threats. So threatening or performing acts to end a relationship, hurt someone, harm themselves, or expose private information about the victim. Using intimidation, so maybe we're going to evoke fear through physical actions on verbal and nonverbal communications. That may include weapon, exhibition, destruction of property, or abusing pets. Using emotional abuse by using humiliating behaviors with the intention of affecting the victim's self-esteem. Using isolation to control an individual's physical and psychological contact with others because of either jealousy or as a justification for behaviors. Denying, minimizing, or blaming. Denying intent of the abuse or shifting responsibility of the abuse towards others. Perpetrators often will minimize the victim's concerns or claims that their feelings are not important. When we think about using children, these relationships with children as a means to cause the victim to feel guilty or through threats of removing children from their living situation. Use of privilege. The victim does not participate in big decision making and feels as if they are not an equal participant. And then using exploitation of resources. So maybe we're preventing an individual from working or controlling those financial resources, and in some cases maybe assigning that individual just an allowance to get by. So when we think about risk factors, the inclination to be violent, angry, or aggressive can occur when a person feels deceived, invalidated, frustrated, attacked, threatened, powerless, or even treated unfairly. These behaviors can also occur when people believe their feelings or possessions are not being respected. So as we look at this list on the slide, these could be some potential risk factors. Have they had violence in the past? Is there a history of mental health disorders? Have they been a victim of a crime? Poor self-esteem, no presence of positive role models, or have they endured some adverse childhood experiences? So when we speak of violence, this is actually the ultimate form of aggression. So murder, rape, other forms of physical assault would be included in that definition of violence. So who's at risk? Substance use disorders, traumatic brain injury patients, PTSD, bipolar, impulse control disorders, ADHD, or even exposure to those violent situations. Let's say a child, right, sees his mother murdered by his father. That exposure to violence puts him at risk for future violent acts. So what are some of the warning signs, right? We have our patient, they are inpatient. We have to recognize warning signs to protect themselves and others from any violent outbursts. So if you recognize any of these warning signs, you must act. Are they declining in eating or drinking? Are they attempting to leave the area before discharge? Are they verbally antagonistic towards you, staff, or other visitors? Have they tried to harm themselves? Are they just staring at you? Are they pacing the floor? Are they trying to destroy any inanimate objects? You may need to take action or be a little more vigilant if you notice any of these warning signs. So let's look at abuse, aggression, and violence across the lifespan. And the first one we can look at, obviously, is our childhood. ACEs, which are acute childhood experiences, are potentially traumatic events that a child experiences before the age of 18 that can really affect them later in life, both emotionally and physically. So they may experience violence, abuse, and neglect. They may see a family member attempt or die by suicide. They may observe violence in the home, or maybe they live in an unsafe or unstable home environment. Children who have experienced ACEs at a young age are less likely to develop adverse health outcomes, including mental illness, as opposed to those who experience traumatic events at an older age. So your birth to maybe 5-ish year olds may not have significant health outcomes. They may still have some health outcomes, but if you're talking about a 5 and up, those may experience a lot more health outcomes or negative health outcomes. Children who are physically abused are highly likely to develop mental health disorders, including behavioral and conduct disorders. The more ACEs the child experiences, the higher the likelihood of them developing adverse health outcomes. Bullying is another concern within our childhood. Bullying can occur anywhere within the school. Students ages 12 to 18 who are bullied believe those who bullied them had more social influence, were physically stronger, had more money, or were able to influence what others thought of them. Online bullying or bullying via text accounts for about 15% of the instances of bullying among this age group. When we focus on our teens and adults, this is where it switches a little bit to more intimate partner violence. So this is physical violence, sexual violence, stalking, psychological aggression to a former partner or a spouse. It usually doesn't require any sexual intimacy, and about 25% of women and 10% of men in the United States are in a relationship with an intimate partner violence, and those numbers go up pretty significantly if you're in LGBTQ. So there are some phases when we talk about intimate partner violences. There are 3 phases with periods of calm between each phase. The time between phases may vary, the cycle will repeat, and individual experiences may be different. So as we look at phase 1, this is the buildup. This can last a few days to a few weeks to even years. There's a breakdown in communication that occurs. The perpetrator initiates more arguments. The environment becomes more intense, and the abusive incidents start. This cycle of violence is applicable in all instances of aggression or violent acts and is not just limited to intimate partner violence. Survivors of intimate partner violence may develop subsequent medical issues related to reproductive, cardiac, digestive, neuromuscular, and skeletal systems, in addition to some PTSD. They are more likely to participate in behaviors detrimental to their health, such as unprotected sex, smoking, or excessive consumption of alcohol. As we move into phase 2, this is the acute battering stage, right? In phase 1 at the end, the violence started. Now we're in phase 2. This could last a few hours to up to 24 hours. It's abusive acts that are filled with rage, that are filled with intensity. Law enforcement could get involved at this point. So I think this is a lot of times where we hear about those domestic abuse cases. And then phase 3 is our honeymoon reconciliation, right? The perpetrator becomes very affectionate. I'm so sorry towards you. I didn't mean to do that. I regret that I did that. I will promise that I will make changes. Unfortunately, it frequently continues to maintain control. They frequently continue to maintain control over that survivor. Elder abuse is a type of abuse that can happen anywhere, and it can occur in any relationship. This is when our elderly population experience neglect, abuse, or financial exploitation, usually on those that are they are dependent upon for their daily cares, including cognitive impairments, physical disabilities, those with very few friends or family members, as the risk increases as the dependency on others increases as well. Rape and sexual assault. Rape includes forcible sexual intercourse, including both psychological coercion as well as physical force. Statutory rape is defined as an adult having sex with an individual younger than 18. Even if that minor consents, it's still statutory rape. Sexual assault involves unwanted sexual contact between survivors and the offender. Within the last 30 years, laws have been enacted in all states in the United States against marital rape. Prior to that, exemptions existed allowing married couples to have non-consensual sex with the spouse and not worrying about legal concerns. When we think about stalking, these are unwanted attention, such as threats or harassment, usually involves an individual that is known to the person being stalked. And then you can see the approaches that are used by the stalkers. They follow, they watch, they obtain entry into their car, into their house. They show up unannounced at their homes, workplace, or school. They make nuisance phone calls, emails, text messages. 40% of people who experience stalking say it occurred before they were 25 years of age, with over 60% of them having experienced actual threats of physical injury. That's a pretty high percentage. So what do we do as the nurse? We have to give equitable and sensitive care. We have to be self-aware, give client-centered care, manage that agitation, and then hopefully help with prevention. So let's talk about some of these. So when we think about self-awareness, we need to think about our implicit biases and our habit-breaking strategies. Implicit bias means our unconscious discriminatory attitudes. So they could trigger negative reactions or fear, which can create a disparities in care. Ethics, race, minority groups, stereotypings, right? If we all say this group inevitably is going to abuse their spouse, that's an implicit bias, right? We're putting them in a box. And it may be based off what you see on the news or what you hear on social media, right? That's an implicit bias. Don't put your patients in a box based off their ethnicity, their race, or any minority groups. As far as habit-breaking strategies, recognize in yourself those biases, right? Those inequitable effects of those biases. And then commit to yourself, I'm going to break that habit. I'm going to look at this patient as a person and not as their ethnicity, their race, or if they are in some type of a minority group. And then practice those desired behaviors. Replace those stereotypes. Practice mindfulness in order to help break the habits that you have had previously. As far as client-centered care, you need to develop that therapeutic relationship. We've talked a lot about how do we develop that therapeutic relationship? How do we develop that rapport, that communication? Make sure that if the culture comes into play, that you're being culturally relevant, that you're allowing your patient to adhere to their culture. And then view illnesses from the client's perspective. Aggression can significantly or signify distress or some unmet needs. So if they're being aggressive, try to look at it from their perspective. That may be very difficult and very challenging, right? Because you just want to be like, knock it off, right? But they are in some type of distress or unmet needs, and we need to figure out what that is in order to alleviate that aggression. Managing the agitation. So if they are getting agitated, right, we're seeing those warning signs, we need to remove them from what may be the trigger, right? Maybe someone in the group is just flat out annoying them, right? We need to remove them from that group. Allow the agitated client some space and time to try to regain that calm demeanor. Ask if there's anything that you can do. Make sure you're responding to that agitation in a very calm manner. Displaying an outward sign of anger or speaking in an angry tone is just going to escalate them. And then be aware of the situation. Don't stand directly in front of the patient or within arm's length, right? If their agitation becomes unmanaged, you're going to be the target. So make sure you're not standing directly in front of them or within arm reach. Make sure you're always standing between the patient and the door. That way you have the way out. Avoid having clients feel that they're being trapped and know the layout of the area. So let's look at care across the settings. So community violence, right? If we have violence within the community, safety is our first issue, right? If we have violence within schools, within hospital settings, right? We've got to make sure our patients are safe. We need to triage. If the violence gets out of hand and we have a patient that is hemorrhaging, we got to control that, right? First, before we move on to maybe less injurious patients. Try to prevent any further injury, protecting airways. If they're hypothermia, right? Try to get warmer blankets. Run or escape if possible. If that's not possible, you want to hide, and then you may need to fight off, but that should be a very last resort for you. Forensic nursing are registered or advanced practice nurses who receive additional education that's very specific to violence or victimization. So a lot of times they're working with the survivors of sexual assault, those intimate partner violence cases, maybe some maltreatment or abuse, older abuse cases. They may even be involved with death investigations. SANE nurses or sexual assault nurse examiners are also nurses who have advanced education in forensic examination of sexual assault survivors, and in some communities these are referred to as forensic nurse examiners. So similar as far as more education with our SANE nurses, they conduct genital examinations, they preserve specimens that are collected as evidence, they can debrief, they can administer medications, and they may actually get called to be expert testimony in a legal proceeding. So nurses do need to follow the nursing process when caring for clients who have neurocognitive disorders and they're showing abuse, violence, or aggression. Because the client may have some cognitive dysfunction, the involvement of family members and caregivers is crucial in assessment and planning. So let's work through the nursing process here. So the first one is recognizing those cues, right? Observe the behaviors and then take a careful health history. Looking at previous occurrences, what is the age and gender, does socioeconomic come into play, and what is their stress level? Have they had recent losses, a divorce, or unemployment? Awareness by the nurse can help to prevent abusive, aggressive, and violent outbursts, and this awareness by the nurse helps to predict potential violence, allowing the nurse to intervene as needed. Recognizing those cues, again, we've got lots of screening tools that we can use. Each of these tools present with a positive and negative attribute, and their use will vary among clinical sites and practitioners. Some of the factors include the length of the tool, how much does it cost, is it very available to the healthcare provider, is it adaptable, and recognizing changes throughout the course of treatment, is there a psychometric reliability and validity in order to use those tools. So you can see several tools there that you might see in the future if you become a psychiatric provider. So as we move through the nursing process, we've done our assessment. Basically, we're recognizing all the cues. Now we need to analyze those cues. So after that thorough assessment, we've gathered data, we can analyze our findings, and what we want to focus on with our patient is that anger and aggression. Many times anger and aggression results from just ineffective coping or unhealthy coping skills. So active listening, establishing a therapeutic relationship is instrumental in establishing trust with our clients, allowing nurses to provide evidence-based care. With clients participating in or being subjected to abuse, aggression, or violence, this is really crucial to preventing injury to self or to others. Clients who have experienced abuse will need to feel safe before they're able to fully engage in their plan of care. Once we've assessed and now we've analyzed, now we can create some goals for our patients. So what are some of those solutions? When we have patients that are experiencing anger, aggression, and abuse, we need to examine different strategies, right? We need to be able to de-escalate. So the goal would be to verbally de-escalate first if possible. If that's not working, then the next goal may be to use some type of pharmaceuticals or medications. Unfortunately, if those don't work, then we have to get to our restraints and our seclusion. So now we intervene and we take some action. So non-pharmacological actions that we can take would be the least invasive. Physical activity, right? We know if we get outside, we walk, we run, we exercise, right? It increases those endorphins, which decreases the likelihood of being bored, which leads to those aggressive acts. Contingency management, right? If they do something really well and we expect or that desired behavior comes out, we need to reward that. Seclusion is limited to the treatment of self-injury or violent clients, right? We don't want to just throw them in seclusion without trying some other things. Definitely trying to de-escalate them. And then restraints would be the last most invasive act that we would do as far as non-pharmacological. But that could be either physical or chemical. So we've previously talked about de-escalation, so I'm not going to go too deep into this. Initially, nurses should implement non-pharmacological interventions and attempt to diffuse the situation by de-escalation techniques, such as introducing yourself, right? Hey, Mr. Jones, I'm Stacy. I'll be your nurse today, right? And that very calm, therapeutic technique. We can use reflection, set limits, and try to empower that patient with some choices. Seclusion and restraints, we've talked quite a bit about, right? Seclusion involves placing a patient or client by themselves in a room or area in which they're physically prevented from leaving. Clients may, on occasion, when they recognize a need for solitude, may ask for that timeout by stating, I need a break. So unlike seclusion, clients are able to leave the timeout when they choose. Utilizing restraints and seclusion should be minimally implemented, only when necessary, ensuring that the current standards of practice are always followed. An important concept to keep in mind is that the least restrictive method of behavior control should be used first. We've talked about this as far as restraints, right? We have to have a prescription. There's some other rules and regulations that go with that. I'm not going to get too into it. I feel like we kind of honed in on that the other day. So if non-pharmacological does not work, then we have to move into pharmacological actions. So long-term control of aggression, these have been, so the patient maybe has been physically restrained. We may need to administer some type of sedating medication, such as lorazepam or haloperidol, which are very common. Healthcare providers should use the smallest dose possible to achieve the desired effect quickly, but not cause any harm to our patient. When oral meds fail, it's common to administer an IM injection. That's just going to get in there a lot quicker. Some of those medications you can see listed there. And then we need to evaluate our outcomes. How did our recognizing our cues, analyzing, generating those solutions, taking actions, how did that go? So a tool frequently used in psychiatric mental health nursing is debriefing, and this involves meeting with the client and other pertinent individuals to review, discuss, and document incidences that just occurred. Debriefing is always completed for clients that have been placed in seclusion or restraints as soon as possible following the discontinuation of those. We need to obtain permission from the client to include family members or other caregivers that may contribute to the debriefing session, as they can provide suggestions for adjusting the current treatment modalities, right? When we debrief, did things go well? What can we do better the next time? And that concludes the chapter. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.